Thank you, Karen. And I want to thank the Nadurni Calciano family and the Dominican Health Foundation for giving me this opportunity to talk to all of you about something that I think is not as understood as it might be, and that is the evidence around the treatment for opioid use disorder. I want to thank Dave for giving us a broad overview of some of these issues, and I'm really going to focus on that treatment issue. And so I'm going to review a little bit about what Dave already talked about. You'll probably hear this again from other speakers. It bears repeating, and I know that's how I learned about opioids and opioid use disorder. And then I'm going to spend a fair amount of time on the medications for the treatment of opioid use disorder, both the existing evidence, some new evidence since I think Dr. Tom McClellan was here in 2013. He may have talked about these a little bit. And I'm going to present some new studies. And then also some things that that NIDA is doing to try to advance this field. I've also got no conflicts. And so just to start with the opioids and opioid use disorder, and I think a lot of people know, but it bears repeating, opioids were originally derived from the opioid poppy. Those are natural opioids, things like heroin, but they can be chemically derived as well. Those are where we get the things like fentanyl and carfentanil. And these things act through that endogenous opioid system in your brain. And again, they attach these mu opioid receptors. And Dave talked about endorphins. They also cause a burst of dopamine. And this is where you get that rewarding feature of these drugs. Your brain says, I want more, I want more, I want more. And Dave talked about how they can be used for pain. And the other thing is they've actually been used medically for literally thousands of years. Yeah, I'm sure you've heard these advertisements about constipation when you're using opioids. Well, they used to be used for dysentery. I don't think we're used that much anymore for those. But they were used for cough and, of course, pain. So what are some of the problems? Well, they're all too real, and you see them, unfortunately, probably every day. What an opioid can do if you take too much of it is it can cause respiratory depression. That means if it's not reversed through something like naloxone, you can die. This is especially true when you have other things on board, especially other depressants like benzodiazepines or alcohol. Because as your use disorder progresses, you may be shifting to injecting the opioid. This can increase your risk for a variety of infectious diseases. People talk a lot about HIV because of what happened in Scott County, Indiana. That's certainly one of them. Much more prevalent is HCV, which is hepatitis C, which is very high in these populations. And also, more and more hospitals are seeing people come in with things like endocarditis and other very expensive to treat infectious diseases that have people in the hospital for a long time. So this is serious stuff. Again, it can lead to problems with your jobs, family, other roles that you may have. It's been associated with criminal behavior. And of course, it can lead to dependence, as Dave had talked about addiction and opioid use disorder. And so Dave touched on this, sort of the difference between dependence and opioid use disorder. And I really wanted to give you one paradigm that's pretty widely accepted. In this field, as with many others, there's always different opinions about things, but this is pretty widely accepted, that the opioid use disorder, in terms of one that you'd want to treat medically, would have both the physical dependence symptoms that Dave talked about. And this is because your neurons are adapting to the repeated exposure. They want the drug, and if you don't have it, you get these withdrawal symptoms. But importantly, for the opioid use disorder, you also need to have this compulsion. You also need to have this addiction. It needs to start taking over your life, essentially. And then you would have an opioid use disorder. And we used to talk about abuse and dependence. Recently, the American Psychiatric Association sort of rethought about that, and we think more about a mild, moderate, or severe opioid use disorder, depending on, basically on the number of symptoms you have. So what are the symptoms? And again, these are basically from the DSM-5, where you go through and ask these questions to get a diagnosis. And it is things like taking more than intended. So if you are on a pain medication, you're not taking any more, you're taking just the dose that you're supposed to take that your doctor prescribed. You may be physically dependent, but you're not taking any more. And importantly, with the second one, you're not trying to control it without the additional amount you're taking without success, then you probably don't have an opioid use disorder, but you may be physically dependent. And if you want to get off them, you have to be very careful about tapering off. You start to spend a lot of time, your focus is really taken over by getting this medication, taking this medication and recovering so you can go out and take it again. You start to use when it's unsafe. So that's where some of these needles come in from which you can get infectious diseases. As you focus and you're spending all your time on getting these drugs, you're going to run into trouble meeting your other social obligations, meeting the needs of your friends and family. You're going to give up on other activities. You're going to start to develop tolerance, which is where you start to need more and more and more to get the same level of, or at least as Dave was talking about, it's not even you're not getting the same level of pleasure. It's just so you're not getting the depths of the bad feeling from using it. And the other things, for a physical dependence, you also need to have this craving and these withdrawal symptoms. And I wanted to focus on the craving and the withdrawal symptoms because that's what at least two of the major classes of drugs that try to treat this disorder really focus on. They try to focus on helping you with your craving and reducing withdrawal symptoms so that you don't go out and use again. And then when you do that, you can start working on some of these other things to get you back into a place where you can have a full life. Let's just talk a little bit about the prevalence of opioid use disorder by age. So this is from a study that our sister organization, the Substance Abuse and Mental Health Services Administration, puts out. This is from their National Survey on Drug Use and Health. It's largely from a household population, but it does include shelters and other places where people reside. It does not include homeless populations. It does not include people in criminal justice settings. So it's probably an underestimate of the actual number of people, but this gives us a sort of general community estimate of what's going on. So what you can see there is that the prevalence that they have in this survey come up with, these are people who have responded to questions that indicate they have symptoms associated with an opioid use disorder. I think they're still using the old system, the DSM-4, so it's abuse and dependence. But that's what this is. So you go into somebody's house. This is mainly done by computer with a headset, so it's not like the survey person. So the last time you used opioids, did you take more than you thought you might? And you can imagine people might not be forthcoming about that in that setting. So what they've done is they've created a computer-assisted interview system with headphones so people can, and what they found is they get more reports of these kinds of behaviors when they do it that way rather than when they have the interviewer. So that enhances the accuracy. But you can see 12 and over, it's about 0.8 of the population. That's 2 million people in this country who have these symptoms consistent with an opioid use disorder in a largely household population. So that's a big number. You can see that about 0.4% of those in the 12 to 17 age group report symptoms consistent with this type of disorder. It goes up to 1.3 in the 18 to 25-year-old, which should be a surprise to nobody probably in this room that that's a very high prevalence rate for that population. And then 26 or over, of course, we've also seen a problem with this. So that gives us an idea of at least a little bit of a breakdown by age. And so now I'm going to go through these medications. And I'm going to start really by just talking about the received evidence for these different medications. Methadone, Buprenorphine, Naltrexone, mainly because that's sort of the order in which approvals were made by FDA, basically. But I know there are a lot of clinicians in the audience, people who maybe either are prescribing or were interested in prescribing. What I'm going to present to you here today is not enough for you to go out and do that in an hour. I can't do that. But I do want to commend to you a couple of what I think to be pretty good resources from, again, our sister agency at SAMHSA. If you're interested in that level of detail, they have their TIP 63, Treatment Improvement Protocol 63 for medications for opioid use disorder. And I think they do a really good job in that document of synthesizing the available evidence. But importantly, as with pretty much every area of medicine I know, the evidence isn't going to cover everything you need to know. So I think they do a pretty good job of also bringing in clinical guidance for clinicians who are interested in doing this and treating these patients. SAMHSA also has a support system for physicians, mainly for those interested in prescribing buprenorphine. If you go to that website, you can get information on how to become waivered to prescribe, but you can also get mentoring. So a lot of times, if you're there in the practice, you've taken your training, you've seen some patients, somebody's going to come in that might have an issue that you're not sure exactly how you want to deal with. So SAMHSA has now provided resources for people to go and ask, and these are localized resources, so you might get matched up with a mentor somewhere near here just to help you think through those issues of how best to maybe treat your patients. And I also wanted to, I'm really focusing in this talk. When I'm talking about treatment for opioid use disorder, I'm really talking about interventions that can help you manage your craving, get you through withdrawal, help you not use, and that will be medication and also other kinds of psychosocial interventions that may be helpful. I'm talking about one of the things that when I just talk to people, I talk to my family, and when you're at NIDA, people sort of ask you a lot of questions and talk to you about their issues with their family people. And whenever I hear about it, I hear things that aren't really evidence-based, that they're telling me about what they've learned about how to treat this disorder. And probably the most important one for me, and the most sort of tragic for me, is when people say, oh, you know, I want to get off this medication. I've been on for a month. I think I can really do it. Or my insurance coverage only covered 2 months of this. Or, you know, I really think that I can't get better until I get off this medication. And, you know, people are, you know, you have your own opinions, and I really believe in patient-centered medicine. That's obviously important. But I think that the research is pretty clear, at least from long-term longitudinal studies and some other things I'll present up here, that this is not a quick one-and-done kind of treatment. This is the kind of thing that for many people, you want to stay on those medications if you choose to be on them for a long time. And what do I mean by a long time? I can't actually tell you that. There's no evidence specifically that says I can say, oh, it's a year. What I can tell you is that there are longitudinal follow-up studies that suggest that it's at least a year for most people, okay? So that's one of the things that I think. The other thing that happened in the substance abuse treatment field is we had a couple of studies that looked at how long you should be in treatment before you get better. And what those studies actually said was it should be a minimum of 90 days. How that got interpreted in practice when we had, you know, payers having to pay for things was 90 days is sort of the gold standard. That was not what that study said, those studies said. And so we turned what I think is really, for many people, a chronic condition into an episodic-based condition, right? So you go in 20 minutes, you go to treatment, you quote unquote get clean, and then you're done. Well, for a lot of people, that's not what it is. They'll go to that treatment, be it 30 days in an inpatient or 90 days in community treatment, and then the relapse rates are pretty high after that. So I want us to start thinking about treatment for this disorder, particularly with opioids, as really a chronic condition. Is that true for everybody? Probably not. I've heard stories. But from the evidence, it seems like for most people, that's something you want to at least consider, staying on it for a while. Now, in this particular talk, I'm not talking about things like naloxone, which is very important, reversal of your overdose. That's a harm reduction kind of thing that I think we're going to get some more information on in other talks. And I'm also not talking about withdrawal management, which is what used to be called detox, by themselves. Okay, those can be very important components of a comprehensive approach to treating opioid use disorder. But by themselves, they are not really going to treat that particular disorder. So I'm not going to talk about them too much. So let's go right into the meds. Okay, so we have methadone. And I said here developed in the 60s. It was actually, as a pharmacological agent, was developed in the 30s to treat pain. But it was approved in 1965 for the treatment of opioid use disorder. Okay, this is what we call a full agonist. It's an opioid. It binds to those opioid receptors. And what does that do? That means that it's sort of doing what your heroin or whatever was trying to do, but in a safer, saner way. So it reduces your opioid cravings because you're not going out there looking for the other drugs that you might be using. It helps alleviate the withdrawal symptoms because, there's an opioid on board. And it can blunt more or block the effects of any illicit opioids that you might want to take. And the thing about methadone and why it was so revolutionary when it came out was because it's relatively long-acting. So if you're using heroin, it tends to be about the life. Again, it's this compulsive use, and generally as your disorder progresses, you need it multiple times a day. That's hard to have another life when you're going out and getting your heroin multiple times a day. So what this did was give people something they could take daily and have that stable dose, or as they titrate it up. I mean, there's an induction period for this, so that they could start to address these other issues so they could have a life. And it was really revolutionary when it came out. And I'm going to throw little wonky slides on here with numbers and all that kind of stuff. And it's because, again, I'm focusing mainly on the evidence. And so what do I mean by evidence? So generally speaking, what motivates me to start to believe something is when I see a bunch of clinical trials, carefully done clinical trials that tell me something, that start to tell me the same thing. So this represents what we call a meta-analysis. A meta-analysis, it doesn't have to be trials, but those are the ones I like. You bring together, you do a comprehensive literature search on whatever topic it is you're covering. You find all the trials, and you grade those trials on a bunch of different criteria that essentially get you to the point to say, do I believe this result, or are there biases here that I really want to question? And there's a group over in England, the Cochrane Collaborative, that does a lot of these. And this is one of the ones that they did. It was 2009, so it's a little bit old. And basically what they did was they find 11, what they called moderate to high quality studies based on a number of criteria. And when you do a meta-analysis, you sort of you statistically and very carefully take all the results of all these different studies together so you can come up with a question. When somebody asks you, does methadone work? You can give a pretty good response saying, it seems to, based on the compilation of the good evidence that we have. So what this one came up with, 11 studies, in total about 2,000 adults. But then different studies are going to have different outcomes, so they had to combine the different ones for the different outcomes. And so I want you to actually look at that second line first, urine use, opioid use, either through urine or hair analysis. They had 6 studies, and that RR there is what we call a risk ratio. So if you are on methadone, according to those 6 studies, you have a lower risk of using opioids than if you're not. In this particular meta-analysis, it was against either weightless control or placebo or, really not another intervention. And there's a star next to that, which says it's statistically significant. Okay, what do I mean by statistically significant? When I'm talking about a risk ratio, I'm talking about something different from 1. Because if my risk of using urine, of using opioids is the same across the two interventions, then there's no difference. Here, it's lower. Now, if you look above, you can see I made a mistake. Because for wait a minute, I gotta back up. You can see there's a confidence interval. Whenever we're talking about basically anything having to do with nature or human beings, there's variability. And that's true if you're doing a single study and you are looking at that result, or you're putting these studies together and you're looking at a result. You always have what they call a point estimate, which is what that RR is, that risk ratio, and then you have a spread around it where you believe with 95% confidence that point estimate actually is. So your best estimate is that point estimate. But you can see that given that life is variable and we don't have perfect anything, it could be between those two numbers right there. And so for the opioid use, I have 0.56 to 0.78. So that's a fairly tight band. And what you normally do with these is you put the lower one on the left-hand side and the higher one on the right-hand side. I didn't do that above. If you look at the retention and treatment, you've got a 4.44 higher risk of staying in treatment if you're on methadone than you do if you're off it. If you're not, if you're randomized to not being on it. But my confidence interval there is 3.26 to 2.04. Yeah, no, that should have been 6.04. I'm sorry, I'm an old teacher. I have to teach people statistics, particularly when I make a mistake. But anyway, so you can see that there's pretty good evidence that methadone does these things. In terms of the criminal activity and the mortality issues, what you can see there is that both of those risk ratios are well below 1. You got 0.39 for the criminal activity and 0.48 for the mortality. But those confidence intervals cross 1. They go from 0.12 to 1.25 or 0.10 to 2.36. That means they're not statistically significantly different from 1. And I presented this, and that is pretty much, I think, representative of a lot of the studies. You have some studies that really do say that criminal activity is reduced, other studies that don't. And it's the same thing with mortality. And even in this population, fortunately, mortality is not that common from a statistical sense. So you often don't find an effect on mortality when you're doing this kind of statistical thing. But the point estimates here give us some idea that at least for some of these studies, it was pretty low. Okay, so that's methadone. What do we know about methadone? So what did I say? It was a daily dosing, right? You had to go there every day given how long the thing lasts. As with any drug, I mean, I always laugh, I don't know if you do, when you watch television commercials and some of these pharmaceutical, these drug advertisements come on, and you see the ladies dancing through the field of flowers, and the guy's playing with his dog or his grandkids, and they're talking about all these things that could go wrong with this drug. Oh my God, all the different kinds of side effects and stuff. And, I don't have a picture. I should have brought a picture of my cat. That would have been a good idea. All of these drugs, if my dad was a pathologist, and if he said once, he said 1,000 times, medicine is a double-edged sword. I can't think of any drug, maybe there is one out there and somebody can enlighten me, that doesn't have some side effects for some people, might have some negative effects. You're always balancing those benefits with the risks. So there are, and I didn't want to come here and say, oh, these are perfect, they never hurt anybody, there's no downside, because that would be not true. But there are some of these things. The thing about methadone is it is a full opioid agonist, so there still is that risk of respiratory depression and death. Again, particularly when you have the benzodiazepines or alcohol on board. The other thing about methadone, and if you're interested in this, you can read it in that tip 63, is it's actually, there's a lot of variability by patients in terms of dosing and titration. So you have to be very careful during that period when you have somebody come in, they would like to be on methadone, you're building them up to a therapeutic range. Unfortunately, sometimes, for whatever reason, there are a lot of different reasons I could go into, that can be a very difficult and unfortunately dangerous time. So that has to be done relatively carefully so that the person can get the full benefits of the methadone. So that's one thing that can happen. There's also some associated cardiac risks that, again, does it happen to everybody? No. What does that mean? Your physician and you should be really assessing your situation around them and be on the lookout for some of them. There's also a lot of drug interactions with methadone. Again, if you've ever read the package insert on any drug that you're taking, there's also a lot of interactions. So it's stuff to be aware of. There's more information in the tip, but it's again, something that happens with most drugs. The other thing that can happen with methadone, when you initially are entering a methadone clinic, and a lot of people I know here probably already know this, you're going to have a daily dosing schedule. You'll be there every day. Now, as you are able to demonstrate that you're recovering from your drug use disorder, you may be able to get the point where you can have take-homes. So you take home these medications. This is really good. You don't have to show up in the really early morning to get your methadone. You can start being much, it just gives you your life back again, which again is the whole purpose of most of this stuff. The thing about it is, and this goes for methadone if you're taking it for opioid use disorder, but also if you're taking it for pain, you need to keep that stuff locked up. Why? Because it's an opioid. And if somebody gets it who is not developed a tolerance to that opioid, they could die. So I was talking to somebody who had a 4-year-old girl, and her father-in-law was on methadone for chronic pain. It happens to be the kind of pain that long-term methadone seems to really help him. But he left his pill around. And the kid was fine, nothing happened, she found it, she gave him the riot act. He was like, I appreciate that you need the medication. I want you to take the medication, I want you to be well, but you do have to be realistic about making sure it's done safely. Lock it up, or what I suggested to this friend of mine was maybe he could stay in a hotel. I get pretty, unyielding about certain things, and that would be one of them. Okay, what do we know about methadone in youth? What we know is that we don't have any trials on them, or if anybody knows of one, let me know, because I couldn't find any, and none of the other people I talked to knew of any. We also know that, I'll get to in a minute, there are regulations on methadone, again, because it's full agonist. There is a place in the regulations where they talk about you can provide it to people less than 18 years under one of these two conditions. Either they've had 2 short-term detoxifications or drug-free attempts at treatment that didn't result in, where the person then resumed use afterwards. And they have a parent or guardian or somebody responsible according to the state that can sign off on it. I don't know of anybody that's actually doing this. I've read other things where they say they can't do it. So I think in the regulations it's there. I'm not thrilled with these regulations, only because I think in the time when we have fentanyl and carfentanil around and you're getting people to detox and then resume use, what are they going to resume use with? It may not be, your wonderful, safe, whatever. So I don't know that these are used, but they are there in the regulations. Now, where do you get treatment with methadone? As I said, methadone is pretty highly regulated. It's what we call what the DEA calls a Schedule II narcotic. That means it has some benefits, but it also has a high possibility of being addictive or developing dependence. So there are regulations. These are enforced by you have multiple people regulating these things. It'll be either SAMHSA or the Drug Enforcement Administration and the State Opioid Treatment Authority. So there's a lot of levels of regulation. Methadone has to be dispensed in an opioid treatment program. You cannot get it for drug use disorder from your neighborhood physician or your neighborhood pharmacy. You can get it for pain. okay? But for drug use disorder, you can't get it that way. So I put there just two of the regulations, that you have to have a licensed physician medical director of the program, and these programs have to make available adequate medical, counseling, vocational, educational, assessment, treatment services. So you have to be carefully assessed before you're going to get on methadone. Treatment programs are supposed to do that. And there's a bunch of other regulations around security and that kind of thing, because again, methadone can be something that people misuse. And so you have to make sure that they can't steal it and stuff like that. And SAMHSA is the one that actually provides the certifications. They actually have a list on their website of all the places in the country that they've certified to provide methadone. This isn't necessarily an endorsement. It doesn't say anything about the quality beyond a minimum certification. But if you're interested in methadone, that's a place to start to go to think about where you might be able to get it. Many of them would have wait lists, so you'd have to probably call around a lot. But at least there's a start of somewhere where you might be able to get it. So that's what I'm going to say about methadone. Obviously, if you have any questions, I'll be happy to answer them later. And now I'm going to talk about another medication, which is buprenorphine. Okay, this was approved in 2002. This is actually approved for those 16 years and older. This, instead of being a full agonist, is a partial agonist. And the reason this was developed was, or one of the reasons, was to try to get a medication for opioid use disorder that would start to occupy those receptors, but maybe in a way that would not be have as high a possibility of overdose, and that would not be as reinforcing in terms of wanting to be able to abuse it. So that's why it's a partial agonist rather than a full agonist. So it's less likely to cause respiratory depression. Again, all bets are off when you have some of this other stuff on board, these other respiratory depressants. So you have to still have to be careful. The thing about buprenorphine is there are multiple formulations, or one of the things about buprenorphine, multiple formulations. So it really came out as a sublingual tablet you put under your tongue, and it dissolves. But there's also a film you can put in your cheek. There's one you can put under your tongue. Recently approved was an implant of buprenorphine, a 6-month implant. There's a subcutaneous injection now that you can get that lasts for a month. It hasn't been approved yet, but I believe a weekly version of that is also in the offing. And so there are a lot of different forms that you can get it in to meet your needs. A couple of years ago, or I can't remember, maybe 10 years ago, they started adding naloxone to certain formulations of buprenorphine. And the reason they added naloxone was to try to make it less divertible, in the sense that people could crush it and then put it in a syringe, and it would meet your drug misusing needs. And there are people who tend to misuse it. The belief was that putting the naloxone on board would really stop that. Didn't really stop it, but it's still a thing one of the things that might help. It also reduces these opioid craving. Again, it's getting on that receptor. It reduces withdrawal symptoms, and it also blunts and blocks the effects. So what do we know about the effectiveness of buprenorphine? It's newer. We don't have as many studies, but it's looking good in terms of keeping you in treatment. That's a big thing. Again, I talked about how really staying in treatment is something that seems to lead to very much better outcomes. So that's a really good result, that it keeps you in treatment. And it also reduces opioid use. This is a standardized mean difference, which is what you do when you have a continuous variable. So this might be something like number of weeks you came in with a drug-free urine or something like that. And in this case, it was more of them for buprenorphine than for the comparator, which in this case was also placebo. What do we know about buprenorphine in youth? We have one study. And this study, it was also reviewed by this Cochrane Collaborative. They considered it a low-quality study. One of the things that happened for this study was that they saw that they were getting such a low amount of, such a big difference in treatment dropout that they felt like they couldn't continue with the study. So they ended it early. They had a data safety monitor for the study, and one of the things they do is they look, as you're going on with the study, should I continue it? And you're going to drop it if it looks like you're hurting people. That's a really good reason to stop it. But also sometimes they stop them if they look like you are disadvantaging the people that are randomized to that control group because you're not giving them the medication. And that's what happened here. So the power's a little lower. There were a few other things that they had about this study, but that's one of the reasons why they call it a low-quality study. But they were comparing 9 weeks of buprenorphine treatment and then tapering them off, compared with giving them 14 days of the treatment and then tapering off. So it's sort of a detox compared to a treatment. And they found significant effects for reducing treatment dropout and also for self-reported heroin use at 12 months. So that was enough to convince them that this could be useful for people. Again, what are the considerations for buprenorphine? We certainly have still, even though it's less likely, maybe a lot less likely to cause overdoses, I don't know that for a fact, but less likely, we still see it, particularly again when we have those benzos and alcohol on board. And then there are other medical things that again, a clinician would really need to have careful assessment and examining some of these things. And again, the side effects. But again, that's something you'd want to consider if you're a clinician. Where can I get buprenorphine? The big difference between buprenorphine and methadone is that buprenorphine can be prescribed really by any prescriber, somebody licensed to prescribe who receives extra training and a special license, what we call an X license. So for physicians, they may prescribe if they've taken 8 hours of training. They can prescribe up to a specific patient cap, so a certain number of patients, and then as time goes on, they can do more and more. Recently, it was approved to allow nurse practitioners and physician's assistants who, within their scope of practice in the state, can provide prescriptions if that's allowed. They can take a longer training. They also have the patient cap. Another thing about buprenorphine, this is starting to emerge. We had a study that showed that individuals who received buprenorphine where it was dispensed. Now, unless you're an ex-licensed physician, you can't prescribe it. But in an emergency department, if somebody comes in and they're like, I gotta get off this, what can you do for me? Because people don't know where to get treatment, and that's one of the places they go. There was a study where they dispensed buprenorphine and then linked them to treatment. And it was a phenomenal number higher who, after 30 days, were in treatment than those who weren't. So that's starting to emerge, and more and more emergency departments. It's still low, I think, but more and more emergency departments are doing it, and we're trying to get the word out through NIDA. And then you can also look, SAMHSA, again, helpfully, has a listing on their website of physicians and nurse practitioners and physician's assistants who are licensed to prescribe buprenorphine. The caveat there is that lots of people do the training. You can do it online. It's free except for your time. And not that many people who do the training actually end up prescribing that much. So you may have to call around a lot here too. But that's basically sort of an overview of buprenorphine. So what do we know about comparison? Now, one of the things I would say about comparing these medications is people like it because they kind of want to know which one should I prescribe. To me, they're different medications. They may be helpful for different people at different times in their recovery, but we still do these studies to compare. And this particular study was actually a follow-up study to a randomized trial with people randomized. These are people who showed up in a methadone treatment program and then agreed to be randomized to either buprenorphine or methadone. Okay, so. And this follow-up study pretty much really looked 2 to 5 years beyond whenever the patient was randomized to see what was going on comparing buprenorphine and methadone. And what they found was, again, mortality, though too high, is, for statistical purposes, not that high. So they saw no difference in mortality between buprenorphine and methadone. They did see a bit of a difference in opioid use, suggesting that those who received methadone were using a little bit less. So buprenorphine was 43% of them were using at whatever time they were followed up, whereas with methadone it was 32%. So there are some differences, but again, I don't like to make too much of them because there's so many other factors that would go into your decision to prescribe. But it is something to think about. In general, if I look overall, there does seem to be some indication that methadone might be more, on average, effective for some things, but it's really a patient choice kind of thing, and really critically depends on working with your clinician and figuring out what's best for you. Then we have the newest one, and I should put a caveat here. So naltrexone has been around for a while in an oral form, but in 2010, FDA approved an injectable form, which is a monthly, which lasts for a month. This is an intramuscular injection. And this is an antagonist. So this works on those receptors a little bit differently, where we had the agonists that sort of activate the receptors. For an antagonist, that really blocks those receptors. What does that mean? So if you take an opioid after you've taken naltrexone, the opioid can be in your system, la-di-da, but it doesn't attach to those receptors. At least there is a way, apparently, to override that block. Not recommended, deadly, but people still try to do it. But that's the basic idea. And so, whereas the other two medications were really about trying to control your cravings and reduce your withdrawal systems so you didn't go get more drugs, this is about, you can take the drugs, don't do it, but if you do, by the way, it's not going to do much for you. So it's a different type of mechanism. One of the things about naltrexone, since it is an antagonist, is that patients cannot have opioids in their system when they take it, otherwise it will not be pretty. So they have to be opioid-free between 7 and 10 days, otherwise they'll be in a what we call a precipitated withdrawal. The thing that a lot of people like about it is that there's no diversion potential. It's a shot, that's it. You're not carrying around pills or anything like that. Another thing about naltrexone is it can be prescribed, and this is true of the oral form as well, it can be prescribed by any licensed practitioner. It's for the extended release, it's a big shot, so they have to be comfortable doing that. But you don't have to go to an OTP, although more and more OTPs are actually offering it, so they can offer all 3 drugs. The doctor does not have to be ex-licensed, although again, an ex-licensed physician could provide it as an alternative. And the other thing about naltrexone is it's also used to treat alcohol use disorder. So what do we know about the outcomes? So the injectable formulation received FDA approval based on this particular study, which was a study done in Russia, where they randomized people to either an injection of the naltrexone or an injection of a placebo. They had a few other things going on, but basically that was similar between the 2 groups. And they found that the median weeks abstinence is really, so of the number of drug tests that we did between weeks 5 and 24, how many of them were drug-free? So it was much higher under the extended release naltrexone than it was under the placebo. And then at the end, when they had confirmed abstinence, it was higher under the naltrexone than it was under the placebo. So that's the study that said, okay, we can now market that in the United States. And because it's new, there haven't been too many other studies. But there have been more in the justice system, so there are a handful of them there. And this one was really another comparison study. Okay, let's compare naltrexone to buprenorphine. Now, the study before that I showed you in Russia, that was a double-blind study. Nobody knew who was getting what. When you're comparing an oral formulation with an injection formulation, people are kind of going to know who got what. And this was done in a community sample. So it's what we call sort of a pragmatic clinical trial. And that's sort of in the community When people know what they're getting, what difference do we see? So it's a different kind of trial. But they randomized people to either getting the naltrexone or in this case, it was buprenorphine naloxone. And what they found was, and this is an issue with the naltrexone, is that fewer people were actually inducted into the naltrexone. What does that mean? Fewer people actually were able to get to the shot because fewer people were able to stay opioid-free for 7 to 10 days after getting out of detox, which is what this population was. So we have with naltrexone what's called an induction hurdle. And in what we call an intent to treat analysis, you look at the whole sample. So that means you're looking at people who are able to induct and also those who weren't. When you look at it that way, you can see that relapse rates were higher under the naltrexone than the buprenorphine, again, largely because of this induction hurdle. But if you look per protocol, that means people who were able to be inducted and received the treatment, then you see more of a comparable response. We've got, I know we don't have any trials on injectable naltrexone with youth. I think there was a trial that I need to uncover for the oral version, but that was in 2005, so I need to find that. But none for the injectable. However, we do have case reports that seem promising. We do know that people are getting prescribed this. Again, you still have side effects, you still have medical issues with these things, and as I mentioned, an attempt to override the blockade, which can particularly happen in the beginning, may result in overdose. And again, it can be prescribed by anybody who is licensed. Okay, so those are the medications. That's what we have in the armamentarium now. But what I'm going to check my time. How am I doing? Okay, boy, I talk too much. I just want to briefly go over the psychosocial treatments for opioid use disorder. And there was a meta-analysis done, and the purpose of this meta-analysis was to say, do specific behavioral treatment. So things like you see listed there, acceptance commitment therapy, cognitive behavioral therapy, those kinds of things. When added to one of these medications, within a period of time that we're doing the trial, does that seem to add anything? And when you look at the results of the meta-analysis, they had 35 studies they looked at, lots of patients, and the answer from that meta-analysis was no. And if you look at all of these studies, and they did the standardized difference, all that kind of stuff, it just didn't seem to have an effect. So I'm like, Well, the other people that said, were two of our really good investigators, Kathleen Carroll, that should be another 2 L's, not 1, and Roger Weiss. And they did a very thoughtful piece in the American Journal of Psychiatry that sort of talked about the strengths and limitations of the studies that were included. And some of the things they were talking about is you need to consider the comparator here. So compared to what? Compared to what you'd standardly receive in a program or in a treatment if you weren't getting the behavioral therapy, or compared to the condition that was provided in that study, which may be far in excess of what you get in a regular treatment program. You need to consider power. Some of these studies were small. You also need to consider other outcomes. So reducing use of heroin, retention and treatment, all very important. But there are other things that may be going on that the behavioral therapies could really help with. And so their conclusion, and my belief, is that we don't really have the answer to that. It's something that we need to study a little more. But, and one of the examples of where I think we need to study more, at least we have more information, is, so we have looked at certain subtypes of individuals. Now let me see, which one am I looking at? Oh, this is for the other. I'm doing a pro and con. I'm doing polarity in my head as we speak. And this is actually a different study than I thought it was coming up. So one of the things about all of these treatments is that you have a pretty high dropout rate. And so there are a lot of different reasons for that. And they wanted to test in this study one of the possible reasons. is sort of the one-size-fits-all approach to treatment. So, right, so if you go to a treatment program, this is Methadone, where you have to attend counseling, you have a lot of rules that need to be enforced, often by the counselor. It gets kind of difficult. They thought, well, maybe if we modeled a different kind of thing, let's just see if we get a different result, okay? So they came up with a way of providing methadone maintenance where people are encouraged to attend counseling, but not required, where counselors are not responsible for enforcing the rules, where they're therapists, where they're helping with regular counseling, that kind of thing. You tried to minimize this idea of administrative discharge. And what they found when they randomized people to these different situations is that there was no difference in the percentage of opioid positive urine screens, cocaine positive urine screens, drug risk score, that kind of thing. But that there was a significant improvement in quality of life when individuals were in the more flexible kind of patient-centered approach. And so that sort of gives you an idea that maybe on average some of that stuff isn't as necessary as we might have thought. And I'm going to skip that because I'm running out of time. The other types of research that we've been doing is looking at what we call interim treatment with medication. So there's several studies of this with methadone, and there's one promising pilot study of this with buprenorphine. So what is this? What is a problem that we have? Thank you. What is a problem that we have with these treatments? A lot of times you'll go and you try to get in and there's no room at the end. A lot of times you have a long wait list for these things. And so the purpose of the interim treatments is to say, maybe we can start in a safe way to get you assessed and get you the medication without immediately enrolling you in the rest of the program. And this is actually the standard of care in other countries. And again, I said there are findings for interim methadone, and this is just one that was done for buprenorphine, where they found a way to safely give the buprenorphine through this meta wheel, which is something that we use in trials. And they found that it seemed to be beneficial for individuals to at least get the buprenorphine compared to just being on the wait list. And these are, people who wanted to be in treatment and so forth. There's a larger study going on that can help that hopefully will confirm that. And I did want to talk about a couple of behavioral treatments that we have and about the evidence that we have. So contingency management, I'm not sure if people know what that is. That's where you are relying on the principles of operant conditioning to give rewards to patients to reinforce positive behaviors. And so that could be things like coming in with a drug-free urine or some other thing that you want to incentivize. And the original version of this was voucher-based. So you gave a patient a voucher for something that they may want that would help in their drug-free lifestyle. There's also a prize-based version where they get a chance to draw a prize for one of these positive reinforcers. And there are other, and then what's nice about that is you can make it flexible over the time period, how many prizes they get to draw for and so forth. And what we find about these, I'm going to skip the next two slides just because I'm running too slow out of time. What we find with these is these can be particularly effective when you have individuals who have both opioid use disorder and cocaine use disorder. And so the point I wanted to make about the psychosocial treatments was that it really is, for what we know now, it's dependent on the patient. Lots of patients come into opioid use disorder treatment with multiple issues on board. So the fact that we have a meta-analysis that says, oh, just giving behavioral therapies isn't going to necessarily reduce your opioid use, that's pretty solid information. That doesn't mean that some people may not need it and may benefit tremendously from it based on the research. And we're going to skip that. Then we're going to talk about cognitive behavioral therapy, another one based on the idea that learning processes play a crucial role in the development of these behaviors, and that what you can do is try to help them sort of unlearn or learn other processes to help them not use drugs. And these would be things like understanding when you are in risk of using drug, self-monitoring, and also learning how to, different strategies or different places not to go or whatever. You work with the clinician to help you help yourself. And what's exciting about this is it's been developed for the computer. So if we're in a place where we're resource limited, an adjunct to treatment could be providing this for individuals using the computer. And it does, again, for those individuals who have opioid use disorder and cocaine use disorder, does seem to maybe have an impact. All right. And patients sometimes do want to discontinue with these. Do it carefully. Do it slowly. And please take some naloxone. Because if we look at cohort studies, and this was a study in Canada, many who discontinue using these drugs for their treatment of opioid use disorder, most of them are going to show up in some way, shape, or form that suggests they've reused. They'll either show up in treatment again, they'll show up in the ER, or they'll show up in the death certificates. So, so if you must, again, we want to be patient-centered, do it very slowly, and there's recommendations in tip 63. And I'm going to skip that and that, and I'm going backwards. Yeah, okay, one little. I think one of the key things that we have here is that not enough people are getting these medications. So this is a study from Massachusetts that looked at data and found out among people who had a non-fatal overdose, how many of them got treatment afterwards with one of these medications. And overall, about 30% did within 6 months of the overdose. It's pretty low if you've got an opioid use disorder. Not everybody who has an overdose has an opioid use disorder, but most do. And then the other issue here with this in Massachusetts was the length of time in treatment. So the median on methadone was 5 months, the median on buprenorphine was 4 months, the median on naltrexone was 1 month. And we see this in other data, that people just either aren't getting the treatment or they aren't getting it long enough. And this is a study that it's a different data set. This is commercial claims, so we don't have methadone on it. But this is a study of individuals 13 to 25 with an OUD, and then looking at them 6 months after, have they gotten the medications yet? And what you can see is, when you're using data like this, you kind of want to see, is there a face validity? So the slide on the chart on the left just says between 2001 and 2014, we saw a big increase in the number of people with OUD in these data. That's face validity. But then you're looking at how many of them actually got the medication. Not that many. Just real quickly. I'm going to go over all 600 studies that NIDA now has looking at opioids and opioid use disorder. Yeah, not going to happen. But you can. You can go to the NIH reporter and do a search for yourself and find out everything that NIDA is doing about this. And you'll see there's a lot, and there may be a lot of interest. And that's how what you get when you show the study. A couple of things that may be promising in the future. Vaccines. Get the opioid in the blood before it gets to the brain. That's the basic idea behind some of these things. We have some recent animal studies that show there may be some potential here. And we've got a human study underway. Again, we know drug development takes a long time. There are a lot of pitfalls that may never come to be, but we're hopeful right now. The other thing is you either want to repurpose or you want to find other targets. So the opioid receptors have been the targets. Okay, what about being very selective in terms of what the target should be and maybe going after something else so that you can leave those opioid receptors there so you can actually use them for pain? And there are some animal studies that are starting to show the way. We also have other antagonists that maybe have less toxicity and maybe more effective than naltrexone. Let's figure out how to use them. So those are some of the things. And I'm going to end here because I had a few other things, but I just talked too much, and I thank you for your attention.